non-Hodgkin's and PTCL. But one of the things I thought was interesting, there was definitely less worry about, the checkpoint inhibitors, particularly 204, like, being a major part of the paradigm. I mean, best case, it would be kind of later lines and maybe in combination. But for some investors, it does feel like, there is kind of an obsession over checkpoints and what that could mean to both paradigms for Hodgkin's and then down the road PTCL. What's your view on that?
Well, checkpoints are great drugs, first of all, and I'm really, as a cancer scientist, I'm thrilled that they are there to help patients and in so many diseases, and so they're great. And they are definitely approved for relapsed Hodgkin lymphoma and are generally used after Etcetras if needed. So our initial approval was in relapsed patients, and we have a very high response rate, but it's not 100%. So there are some patients that break through and need other therapy, and I'm glad that checkpoints are there. And our initial approval generally was after, the patients were treated with Etcetras, which is the order doctors generally use them. And there could be an exception somewhere that one doc you find says, oh, I use checkpoints everywhere. But generally they use Etcetras prior to the checkpoints, and they use the checkpoints if they need. Now, Merck got approval for that, but had to do an accelerated approval, but had to do a confirmatory study. So they had to design some confirmatory study somewhere, somehow. And they designed one called 204 that compares the two. And, I haven't seen the data. I don't know what the data will be. But that's in late-stage patients. And when you actually look at late-stage patients, there's so much data that we have put out, and including in guidelines, of like using Etcetras, for example, with bendamustine, where you have a response rate of like 90% or so and a CR rate of like 80%, which will be way, way, way above a checkpoint by itself. And so in guidelines now, you have Etcetras combinations that docs can use with very strong data. Our data with Etcetras plus checkpoint inhibitors are also extremely strong, and we've presented that. So at this point, doctors I don't see them running to use single-agent checkpoint, which has a lower CR rate. I mean, they've already done a lot of studies. They had a lower CR rate by a long shot than Etcetras. Where the checkpoints shined was they had a fairly substantive DOR, duration of response. And that's where, a study like 204 may just track it for long, long periods of time and say our duration is higher, because I don't think there's a chance that their response rate is going to be higher, but the duration may be higher. And that's good for patients. But that's also why a lot of docs are using the checkpoints plus Etcetras to treat the relapse patients. But it kind of gets away from our main thrust, which is let's cure patients so they don't even go to relapse. And let's cure them with Etcetras AVD up front. And, I can't say we have a higher cure rate yet until we have the OS data. But when you look at the data as it ages, it sure looks like that's what we're going to get. And, I look forward to seeing that. And let's try to cure as many patients as we can.
Yeah, I mean, there's a lot beyond just PTCL and Hodgkin's. And, I mean, we count, almost 40 investigator-initiated studies. I mean, is there, for the Etcetras pipeline, if you want to call it that, like what would you say is your maybe top 2 or 3 priorities with respect to clinical development? Because I know, you mentioned the 6 indications that you have, and it definitely seems like there's a lot more to come down the road.
Well, I think that one of them, for example, that I'm excited about is DLBCL, which is diffuse large B-cell lymphoma. It's a market opportunity that's substantial. We already have a pretty big data set showing that it's very active, and in fact, it's in guidelines because we have a data set showing in patients that have had, I don't remember exactly, I think it's 3 prior regimens, but I'm not exactly sure it's 3 or 4 or whatever. But these are regimens that have Rituxan, Rituxan-based regimens, starting with R-CHOP, but then you could get R-bendamustine and R plus anything. And but at some stage, they stop responding to Rituxan regimens in some patients. And we have a 44% response rate with a single agent, nothing even added to it, no regimen. It's a single agent, well-tolerated outpatient therapy at that very late stage. So I know of doctors that are interested in this and use it. I was at a major medical center on the East Coast talking to doctors about Hodgkin lymphoma and T-cell lymphoma, and the doc said to me, I use this to treat B-cell lymphoma patients, and I get about a 50% response rate. I really like the drug, and it's in late stage when there's Rituxan is not working in these late stage patients. And, to say he gets a 50% response rate like he did, clearly that's not statistical or not in a big study. He just feels half his patients are responding, and our data at 44% is not that far away, so I can see why he thinks half his patients are responding. But it shows you the power of Adcetris there, and certainly that's a good subject to speak with regulators about and try to figure out how to get a label, because right now we're just in guidelines, and some doctors use it, but I'd like my reps to be able to talk about it and present it to docs and make it, make a good mind, have a good share, of the voice talking about B-cell lymphoma. That would be really, really nice. And so that's one option. Another one, as we talked about earlier, is stage 1 and 2 Hodgkin lymphoma. Another one is mediastinal B-cell lymphoma, where we have extremely good data. Another one is retreatment. Now, some docs use Adcetris and they retreat with it because they don't have to stop according to the label. When we sent our first retreatment data to FDA, they changed the label because it used to have 16 cycles as a max. That's 1 year. And when they saw our retreatment data, which was 70% response rate of patients that initially responded to Adcetris, and at some later time point had a new lesion and then got Adcetris again, 70% re-responded. And so FDA took off the 16 cycles max to allow doctors to use Adcetris as long as they want. So there's no maximum amount of cycles to have. And that's in the label now. But we don't have retreatment in the label in those words. So it would be nice to consider getting that there as an example. So I just read a few things, but there's a couple more, but we haven't really talked about them yet.
Okay, that makes sense. Well, let's shift gears to the non-Adcetris pipeline. Obviously, there's a lot of talk about EV with the urothelial data coming up. I guess any day for you guys, because you guys said 1Q. Give us a sense to bookend. I think you guys have said 20-25% response rate, 6-month duration of therapy would be pretty viable, considering that checkpoints have done far less than that, and refractory urothelial is pretty nasty. But want to get kind of maybe an updated view on that from your perspective, Clay.
Yeah. So yes, the EV data is coming out this quarter, which means to have it come out this quarter means it has to come out no later than next, because the Monday after is April 1st. So what I can tell you is, it will come out.
You got a week, yeah.
So it's going to come out soon. It's kind of interesting. It's so funny as some Wall Street folks have said to me, it's taking longer than you thought. There's a problem, and it's like, and that's kind of funny. It makes me laugh a little bit, because what we did is we worked with regulators. We have breakthrough therapy designation. We work with regulators, and we're doing a study that looks at the primary endpoint is objective response rate and duration of response, and also CR rate. So you have to look at different endpoints, and we work with regulators, and regulators will say, okay, let's make sure you get all your patients on, and then make sure you wait a certain amount of time from the last patient on to look at duration of response, because we want, X percent, let's say 85% of patients for at least this many months and stuff like that. So we've known for a long time exactly when the data's coming. So this isn't an event study. This is a time study based on letting it go for a certain period of time. So it is not going longer than we expected or shorter. It's going exactly as we have outlined with regulators, exactly to a T. So first of all, I just want to discount anybody saying that there is any issue. There is not. Second of all, we recently put out updated data I think it was at ASCO GU or something like that. It was updated phase 1 data, and we actually, the response rate was, I think, 42 or 43%, and these are in patients that had prior platinum and a prior checkpoint, so technically, the third therapy they were getting, and with a 43, I think, % response rate with a duration of response of 7.4 months, which is why we have breakthrough therapy designation. The second line gives you a response rate of about 20%. And so we're doubling up. In our phase 1 study, we're doubling up the second line response rate. And not only that, but when you look at the waterfall plot, almost every patient has a declining tumor volume. So it's all under the line, and there's tons of patients that are near responses. So if you're a doctor and you're treating people, and this was on the market someday with those kind of data, you could look at your patient and say, I have a drug for you that will shrink your tumors, and almost everyone's tumors, 90-something % of tumors will go down. And doctors, once drugs are on the market, don't say whether, if you have a PR or you're 1% lower than a PR,